So domain three, provider query. So in the provider query, so we'll be looking into the few topics. Those this six topics. One is identify elements on ethical complaint and provider query. Another is determine if a query is complaint with high mass standards. And third is like analyze the current documentation to identify appropriate query and opportunities. And the fourth topic will be like formulate queries that not leading or biased, understanding when and when not to query the provider. And sixth is like ensure queries comply with regulations and ethical coding standards. So these are the some of the topics which includes in the domain key. So this all together we call it as provider query. Okay, first we'll see into the elements of the ethical and complaint of provider queries. So if you see this, so here, so what are the standards based on the HIMA? What are the standards that the documentation should be there? And what are the queries should be asked based on the documentation? Okay, so we cannot ask whatever we assume. Okay, either we have to ask when there is an improper documentation, or I need to ask when there is no clarity in the information which have been provided. Okay, so based on that, they have been segregated different topics, and based on that they have segregated different set of queries and how and when and what type of queries need to be asked with the provider. That is what very important, because if you see not only in the inpatient, even in the outpatient setting, where we may end up with a lot of clarifications, where we will be always in the confusion to come to the conclusion in the documentation, even though the documentation is crystal clear. Yes, it may be legible, but when there is a lack of understanding in the concept, lack of understanding in the guidelines, lack of understanding in the client specifications, what we do, we always assume ourselves. Okay, so this all brings like starting from the trainee coder till the experienced coder, they used to face this kind of scenarios, because the upcoming trend in the medical coding, how it has become is like the quality training and the quality concept, okay, concept making and guidelines understandings are completely getting eradicated. But the main reason is now it has become where I can just do the repeated scenarios. For the repeated scenarios, I can use the repeated codes so that my quality may stand near to 95 to 98. That is how the repetitive work, replicated work has become more. The true analyzation, the true understanding of the concept, we have a lot of gap. That is, we call it as knowledge gap. And that knowledge gap can be filled by sharing the knowledge. Okay, this is what happens with the experience as well as with the fresher. So the experience should share their knowledge. The knowledge which they gain through their understanding of the concepts and the guidelines is very important. Because of that, what is happening? The deviation starts there and it is leading to the physician. So there are so many junk boxes, or there are so many feedback boxes, and there are so many addendum boxes where it is getting piled up. And because of that, we are getting a lot of denials in the reimbursement, incorrect reimbursement, because we keep on go back and inquiry the physicians incorrectly. Okay, so yes, it is not something like you cannot query back the physician. We have to query the physician when we don't have the proper information, and when we don't have the legible information to process the documentation or to code the CPT code or ICD code or PCS code. Yes, in that scenario, I need to go back and ask. But when there is a question, there is a way to ask. Okay, I cannot use my own English or something like I cannot give a vague questions, or I cannot raise a vague documentation questions. Okay, these all are very importantly we need to monitor. So to bring that in the control, they made a step by step of process. They made a step by step of elements and criterias so that we don't make the mistakes. Okay, so first, so query clarification, they do not create diagnosis. So that is what the main point I added here. They do not create a diagnosis. So the query is to get clarification. It's not to bring what is the problem the patient is having, and or what is the abnormality the patient is having. Through the query, I cannot ask any CPT codes or ICD codes. I cannot ask what type of condition also. Only thing is like I need to get an optional clarification through the provider query. Apart from that, I cannot create any diagnosis with that. So that is what the main thing we need to follow, especially in the exam point of view also. So make sure we are not taking any diagnosis. Okay, we need to be very clear on understanding the question whatever they provided. Through the question, I need to come to the conclusion what type of query I am going to be, what type of categories of query I'm going to ask. That you need to control. And you cannot think like whether so. What is happening is like we may end up with thinking some diagnosis code should come. No, it is not. It is not a thing. When it comes for the provider query, we need to go back and question. Now, what type of question, how the questions are going to be asked. So that is what we are going to see overall here. The core requirements elements here, if you see, patient identifier, clinical indicators, statement of issue, neutral question format, and non-leading language and timelessness. So when it comes for the patient identifier, so for a patient identifier like name, MRN number, DOS, yes, this all can be queried when you have the doubt in that. But when there is a crystal clear documentation, it is not correct going back and asking whether the physician on the name or MRN and DOS is here and there when it replicated reports or the addendum reports or patient with the different specialties coming to the one specialty, those scenarios, yes, we will be checking for the patient identifier. Next is like clinical indicators. Okay, so the documentation which are the provider related to the lab reports, vital reports, imaging, medications, progression notes, yes, this all we can be carried out, no doubt in that, but it must be objective and documented. As I said, objective means it is like physician should be told very clearly. Subjective means from my side. Objective means from the physician. Physician should have been told very clearly and it should be documented. In that scenario, if you don't understand, in that scenario, it is not matching, that standards are not matching, yes, you can go back and ask. If you see, one example, if you wanted to, when they're checking for the lab reports, if you take like ejection fraction, based on the percentage, okay, you can come to the conclusion, especially ejection fraction of the heart rate. Based on the percentage, you can come to the conclusion, what type of failure is having, what type of heart failure is having, whether it is systolic or diastolic, okay, less than 30%, greater than 30%, near to 60% of ejection fraction. Based on this, they are able to come to the conclusion, okay, that the patient is having certain condition in the heart. But when the standard guidelines is provided, but physician is giving different value, then yes, I can go back and query because based on that, because I'm dealing with the congestive heart failure or any other type of failure, okay, they're related to the heart failure. So that which is going to lead me for the very high priority code and higher payment. If I'm going to assume and code, then I will end up with the incorrect billing. So the objective, the documentation should be clearly given by the patient and the documentation should be available. Then statement of issue. So what is unclear, conflict or incomplete? Okay, so when it is unclear or when you have some kind of conflict between the documentation, like we have discussed earlier, like progression note on documentation will be there, discharge note on documentation will be there. Yes, that is what a conflict we can go back and ask, and incomplete documentation. So when they give there, then there is a chances of addressing the condition with the acuity, whether it is a chronic or acute condition or subacute condition, or whether it is going to be the initial or whether it's going subsequent. When that is not given completely, when the documentation is not given completely, yes, I can go back and ask. Okay, those are the statement related issues when it comes for the complaint provider query. Then natural question format. Okay, so in what type of, okay, what type I need to question, not natural, neutral question format. What type I can ask the question. Okay, so what they're trying to tell is like your question should have the full stop. Your question should have the full stop. It should be easy understanding for the physician. And the same time, you need to provide a choice. Okay, so through the documentation misunderstanding or through the documentation, what are all the other chances or other possibility options you are getting? Say for example, if I have some clinical features, okay, say for example, we'll take one small example. Stomach pain is coming for the stomach, abdominal pain is coming for. When they say abdominal pain, there is possibility where I can relate that to hundreds of conditions, right? Hundreds of conditions I can relate. Okay, in that scenario, when the documentation is not clear, I need to provide an option for the physician asking that for this abdominal pain, based on the present clinical features for this abdominal pain, can I consider this as cirrhosis or gallbladder stone or pancreatitis? Like that, I need to give some options. If I provide the options, the physician will be have even more clarity. He will not go for the further analysis and he will not spend so much of time. So he will directly give the answer. And the same time, open end means the question should be very open. In the same time, it should have the full stop. You ask one question, he will reply. Again, you go back and ask. Again, he will reply. That will frustrate the physician. So we cannot do that. So open end, multiple choice, free text. These all are very, very mandatory format which we need to use. That is what called neutral question formatting. Then no leading language. Okay. Avoid the suggestions, a preferred diagnosis says that you cannot do. He is a doctor. You are not a doctor. You are just a coder who have been learned things theoretically. Yes, you're just following what are the instruction is provided. Okay, you can analyze. but you cannot suggest to the physician. Definitely, they will come back in different way. That is what one more thing. No leading language. Then timelessness during encounter or prior to the final billing. That is very, very important. Okay. Before the billing, your questions should be wind up. After the billing, you cannot go back and question. Again, that will cause double work from the scratch. Okay. We call it as Scrum Bag Masters, we call it. Okay. We have one separate process. Okay. Scrum Bag Mastering, one of the process in the coding, where I need to start from the scratch. I need to analyze each and everything from the pre-registration, then the what is that, a treatment, consultation, then whatever the steps they have taken, from everything I need to come to the conclusion. Okay, that is what they're trying to tell. So don't go. Timelessness is very, very important. So don't go beyond the billing. Before the billing, whatever you wanted to do, you do it. Okay, so the format, HIMA complaint to query format, opening multiple choice with reasonable option, yes or no, only when appropriate. Okay, yes or no, which means like present on admission condition. When you're confused, you need to end up with asking yes or no for present on admission conditions. You cannot go back and ask other clarification when you can able to ask with yes or no. Okay, some example I provided here. You see here, complaint query. Okay, here he has come for the acute kidney injury, clinical indicator. Creatinine is increased, urine output is decreased, IV fluid is administered, nephrology consult. Okay, so now these are all four scenarios where you can relate not only for the AKI, you can relate to the chronic kidney disease also. Now, if you're telling to the chronic kidney disease, what type of disease, whether with the hydronephrosis, without hydronephrosis, because they're talking about urine outflow is reduced. So why urine outflow is reduced? Maybe it is having some blockage. Okay, that is the reason you get hydronephrosis. Okay, maybe in the ureter you may have the blockage, or in the bladder you may have the blockage, or in a kidney line you may have the blockage. Because of that, only your output is reduced. Okay, so what would be the reason? So you can give the option. See here, query based on the documentation, increase the creatinine and decrease output. You can clarify the patient renal condition, whether it is acute kidney injury or chronic kidney condition, or acute and chronic kidney condition, or non-clinically significant renal condition, or other. Okay, when I say other, you can use an other option, or you can go with other set of disease condition also. Here I'm directly relating with the acute kidney failure as well as the chronic kidney disease. You can add one more also. You can add renal insufficiency also. You can add, or you can add kidney stones also. You can add, because creatinine is increased. You can relate directly to when creatinine level is increased, means it is related to kidney stone. Here urine output is reduced. Yes, kidney stone will be there. Okay, then fluids are administered. Yes, sir. When the patient is not able to urinate properly, they will increase the fluid content in the body. Then nephrology consult. See, if you take all these clinical indicators, by this I can relate so many conditions. So I need to mitigate the conditions, and I need to provide which condition is properly related to query this. Okay, that is what comes under the complaint query. So in the complaint query, what basis we are talking this as complaint query means there is no related relation between relation for anything like patient identifier, or documentation is not clear, or something like it is not like where I'm not able to understand the documentation or conflict in the documentation. Everything is clear, but I'm not able to finalize what is the final diagnosis. As I told, I cannot lead the language, no leading language. I cannot conclude myself. Okay, these all the critical indicators are there, so I will consider this as a chronic kidney disease. No, you cannot go like that. You need to check with the physician very clearly. That is the reason. Complaint means I need to go back and check with the physician. So something like I cannot conclude where physician has to conclude. That is what you are going to question. This is one type of query type which we are asking for the provider. Then if you see the next one, determining if query is IMA compliant. So we need to verify, use the decision filters. So here, so one more scenario provided, okay, determining if the query is IMA compliant means, see, these are certain criteria required. Okay, so if you see in the scenario A, patient with the heart rate, okay, then oxygen rate, then ABG and BAPAP, okay, no respiratory diagnosis documented. Okay, see, now if you see, the vitals are completely related to the respiratory system. The vitals are completely related to what? Respiratory system, because this RR rate and O2 rate and ABG rate and BAP, okay, these all are related to the respiratory system, where you will not be able to come for some conclusion. See what is the diagnosis he has provided here. He is just giving, he has just given only one thing here, that is no respiratory diagnosis. But if you see everything whatever they provided here, this all related to the respiratory, right? So if you see BAPP is like on BAPAP, sorry, PAP and ABG. So BAP, you are understanding like positive air pressure, we call it as. Okay, it is like bi-level positive air pressure, and what is that? Oxygen level, oxygen saturation level. Okay, this all, if you see, it seems to be abnormal. But if you see, patient is having no diagnosis for a respiratory system. Can you clarify respiratory condition being treated? So that is a question mark. Okay, what is the question is asking? There are so many abnormalities for the respiratory system. The vitals are abnormal, but there is no respiratory diagnosis. Now, what is my question? Did you do a treatment for the respiratory condition? So that is what I'm going to question. So there now, why I'm getting this query mind, because of the abnormalities. Okay, so that is the reason I'll be determining the query. That is the reason I'm just checking with the physician whether I need to consider anything related to the respiratory system. If you see the second scenario, patient with mild hypoxia on the 2N oxygen. Query, is this acute respiratory failure? So patient is having hypoxia, mild hypoxia is there on the oxygen is in, like they have given the ventilation. Okay, now we are not very sure if it's hypoxia means it is an indication for heart failures or respiratory failure or not. At the same time, if it is respiratory failure means what type of respiratory failure? It is acute respiratory failure or chronic respiratory failure. That kind of questions will come. Since it is a mild one, yes, I need to check whether it is a acute respiratory failure or not. Okay, here it's a non-complaint, assuming diagnosis without a strong indicator. So there, whatever the clarification previous example you have seen, with a strong related diagnosis, clinical features, we were doubting we are doubting the condition or abnormality, and we are querying with the physician. Here, we do not have the pakka clarity. By only keeping the mild hypoxia, I cannot conclude with this, it as a respiratory failure. There may be any other reasons also. So that is the difference between the complaint and the non-complaint. Complaint, which I will have the clear picture, what I can ask and what it is related to. But where it is a non-complaint, I will not have the clear picture whether I can, whether I should query or I should not be queried. There will be confusion. Still, since you don't know what is the final condition, I need to go back and query. So that is what make the difference between the majorly for the complaint and non-complaint queries, provided queries. Okay, so these are the two examples. Then next one, if you see, analyze the documentation to identify the query opportunities. Okay, yes, I have some conflict in the documentation, or I am not very clear. Only based on the clinical indications, clinical indicators, I'm coming from certain conclusion. In the clinical indicators also, I can again segregate as whether it is a complaint based or non-complaint based. Now I have concluded it is coming under complaint or non-complaint. Now, when I'm going to query, what are the things I need to verify? What are the documentations I need to verify? Where are the areas I need to verify before going and asking with the physician? So if you see that, appropriate query situations. Okay, we have created a query situation. Simultaneously on the right side, we have the questions for that also. You see, conflict in the documentation. Okay, so ED note says sepsis, where discharge summary says UTI. Now, based on the ED note, it is sepsis means in the discharge only summary is there means, then what about the sepsis? Whether sepsis is present or not, whether it is resolved or not resolved. That is a conflict. Only with the UTI, I cannot, because the hospital acute condition may be UTI. But what is the POA sepsis? In the discharge summary, that sepsis need to be documented. Otherwise, at least they need to explain what is the situation, what is the status of the sepsis. If I don't know, yes, definitely I need to query back. That is what they're querying. Query needed to resolve the conflict. Whether sepsis is there or not, whether it is resolved or not. That is what my query is going to be. If you see the next one, clinical indicators without diagnosis. So previously we have seen that complaint example, right? That B scenario, same way. Creatinine 3.2 and oliguria is there. No renal diagnosis. Here, we do not have any diagnosis related to the renal. So I need to come to the conclusion based on these two, what is the problem? What would be the problem? Okay, if you see one example I provided here based on that, WBC 18,000 is there, temperature 102 is there, heart rate 120 is there, blood culture is positive, no sepsis is documented. See, these are the clinical indications for the some of the infection. So here I'm directly relating to the sepsis. So there will be the query. So these are the clinical indicators supporting for some infection, but where is the diagnosis? The diagnosis, nothing is proved. Same way here also, two different conditions is there for the two different abnormalities are there for the kidney, but what is a kidney related condition? So I do not have the clarity there. Yes, I'm going to go back and check with the physician what is the diagnosis for this. Then lack of specificity. So previously I told you, like they need to mention what is acuity. If you see congestive heart failure, pneumonia, anemia, these all need even additional clarity, specificity, which means pneumonia means what is the organism infected. Say for example, CHF means whether the systolic or diastolic or combined, acute or chronic. That type need to be specificity should be addressed. In anemia means what type of anemia? Sickle cell anemia, drug-induced anemia, chemotherapy anemia, cancer-induced anemia. What type of anemia that need to be addressed? So that specificity should be there. If it is not there, I'm going to query back the patient. Cause and effect missing. Okay, so post-operative wound infection, is it a complication? So when I come in for the complication, that need to be very clearly addressed. This complication is because of this post-operation, or this complication is happened not because of this post-operative wound. Like that, there should be a clarity in the documentation. If I don't have the clarity in the documentation, which is also called cause and effect missing. So what is the reason for the complication? What is the effect because of this complication? If that is not addressed, yes, definitely I need to worry back. Then ask uncertain terms, yes. So in outpatient, yes, this is going to be not a problem. But when it comes for the inpatient, depending on the documentation, yes, I need to check for suspect, possible, probable, likely, borderline. Okay, these all are the some uncertain terms where I need to go back and get in clarity with the physician. Okay, so these are the type of identified query opportunities. So where and all I can question, what and all I can question in the documentation. So we can tell it as a documentation gap. Remember, in the exam point of view, they're going to ask you this as a documentation gap. Okay, so when we shouldn't be queried, do not query when diagnosis is clearly documented. When diagnosis is clearly documented, only one possible interpretation. When there is only one possible interpretation is there, means I cannot go back and yes, sir. If creatinine level is 3.2, oliguria means I can directly tell it is a kidney failure. When there is a conclusion based on these two clinical indicators, if I'm able to conclude that is a chronic kidney disease, say for example, chronic kidney disease stage 3, again I cannot go back and query whether it is a 4 or 5. These two clinical indicators are clearly interpreting it is some renal problem. It is a chronic kidney disease, the renal problem. Again, I think about what type it will be, whether it will be renal insufficient, whether it is acute. No. If these two indicators telling directly, straightforwardly, directly proportional to kidney disease means stop there. Don't go back and ask. Okay, that is what they're trying to tell. Only one possible interpretation should be there. The next is like query is solely for higher reimbursement. Yes, very important. Simply for some namesake, I cannot go back and ask. So the ICD code which I'm going to code, that is going to make the payment different. Okay, if that is going to make the payment difference, which is like usually I need to get some $10. This ICD which I'm going to code, it is going to lead to $6 or $7, but it is actually need to bill for $10 means yes, I need to go back and query. But the question which I have, it is already going to cost $5 or $4. Again, when I'm going to code incorrectly, also it is going to cost $10. It is better not to go back and query it. It is better to go by the documentation for the for the high reimbursement. Okay. Then clinical evaluation, evidence support condition. No clinical evidence supporting condition. Yes. So when there is no sufficient documentation for that, no sufficient evidence for that particular condition, we shouldn't go back and ask the question. Okay, so these are the places where we need to avoid questioning the physician. Okay, so keep that in the mind. These all are called the documentation gap. Then formulating the non-leading and non-biased query. What is leading? Okay, so patient has evaluated with troponin and chest pain. Is it what is that? Non-STEMI. So if you see here, what is happening? Okay, so what they're trying to tell here is like, so by keeping this elevated tropophenine and chest pain, I cannot just go back with the non-STEMI because same scenario will be leading for the STEMI also. So what they're trying to tell means it should not lead. It should end up this the question whatever you're going to ask. Okay, the condition whatever you've seen or abnormal whatever you've seen, you cannot just end up with one condition because the same both abnormalities will be related to different conditions. Even for you can consider this for the ejection fraction also you can consider tropophenine and chest pain, elevated troponin and chest pain also. You can consider for myocardial infection also you can consider. Again, it is for non-STEMI also you can consider. And you can consider for failures also. Simply you cannot ask only one question. It should not come back like physician may come back asking like in what basis you are telling only it is STEMI, non-STEMI. I will tell this as a STEMI because elevated troponin and chest pain is there. So like that he may come back. So it should not lead further. That is what it is called non-leading. The way you are going to question him, it should not ask you back. The physician should not ask you back what is the next one. Okay, see some example, complete version open end. One more is like open end. I have given the example. Clinical indicator, like troponin 3.4, chest pain, ST depression on ECG. Question: can you clarify the clinical significance of elevated troponin and ECG findings? By that, you are creating an open-end question here. That is what open-end question means, whether it is a type 1 non-STEMI or type 2 myocardial infection or myocardial injury. You are giving that options. Okay, you are providing that option. So this is very, very important. Okay, so which is like you are providing, we are making the physician to not to think a lot. By this can these abnormalities, these vital abnormalities, what are the chances for the problem? Okay, that is what you are going to end up with. What type of questions, what type of conditions I can ask by based on this clinical indicator. You see here the difference, okay, for leading versus non-leading query example. See, leading, patient meets sepsis criteria. Please confirm sepsis. So you cannot go back and ask when there is a clinical indicator very clearly it is telling it is sepsis. Again, it is no use of going back and asking whether it is a sepsis or whether it is a urosepsis or septic shock. We cannot. Okay, whatever the criteria it's supporting for, you're going to ask. When it comes for the non-leading, okay, we call it as open end. Okay, non-leading means open end. See the example which you have seen, right? So if I have certain condition, based on that, I'm giving one chance for you. So those are called a non-leading or open end query. So here, based on the elevated WBC, fever, tachycardia, and a positive blood culture, can you clarify the diagnosis associated with the findings? See, bacteremia, SARS due to infection, sepsis, localized infection only. I'm giving some option. So Fusion, he has to choose any one of this. He will not go further and do further analyzation or he will not come back. Okay. So when the clinical indicators is given, you cannot come up with only one condition. Say, for example, STEMI and sepsis. With one condition, if you're giving, Fusion may come back. Okay. When you ask open-end questions, this and this is there, or this can I conclude with what are the conditions related to this clinical indicator? Then it is very easy for Fusion to tick the condition and it will be very easy for you to take the answer. Then next one is like when to query, when to not query. Okay, so just keep it in mind. Okay, so missing specificity, yes, I need to query. PO is unclear, yes, I need to query. Conflicting in the notes, yes, I need to query. Okay, and diagnosis is clear, no, I cannot query. No clinical support, yes, I cannot query there. Okay, mild anemia lab, but no treatment, I cannot query there. So these are the some of examples I provided where I can query, where I do not query. Okay, see again other things. Query when documentation is ambiguous. Okay, ambiguous means it is vague. Missing severity, like whether it is MCC or CC impact is there, that is not given. Yes, we need to go back and query where it is necessary to query. Clinical indicators suggesting additional diagnosis, I need to query. POA status is unclear. Procedure intent is unclear. Yes, these are all the areas I need to go back and check with the physician. Areas where I don't want to verify is like diagnosis is already definitive. No clinical support is there. Attempt to introduce a new diagnosis, trying to alter the principal diagnosis improperly. Okay, so these are all scenarios where you don't want to query the physician. Then the last one is like regulatory and ethical standards of governing the queries. Okay, here I need to follow certain ethical standards. That is very, very important. So CCS expert knowledge of HIMA query practice before. So we need to follow the guidelines whichever provided by the HIMA to do the queries. Okay, that is very, very important. Okay, so I need to follow definitely on the HIMA queries. If I don't follow that, then I will be end up with the asking improper question. Then physician will come back and he will excuse me in a different way. That is one thing. And the second thing is like we call it as ACDAS guideline, which is Association of Clinical Documentation Integrity Specialist. Okay, so they are like one is a we we might have come across some of the specialties in recent times. They're talking about just a moment. So here might have come across some of the specialty in recent days. We call it a CDA, right? Clinical documentation specialist. They're asking for integrity specialist. They're asking for, okay. There is a separate association where they create a documentation. The documentation should be very clear and they have certain format and policies. Based on that only, either it is outpatient or inpatient, especially the inpatient, the documentation should be designed in such a way. Okay, that is what important one. Okay. That is what an important guideline we need to follow. So the documentations we need to verify, and based on the documentation guidelines only we have to follow. Then CMS official guidelines. So that is like the standards which they are following for the CMS is like they will be telling how the documentation framework will be there. how the integrity will be need to be followed, what are the mandatory things will be there. So this all will be given through the CMS. Then last thing is like UHDDS definitions. Okay, so USDS definitions which will support for the principal diagnosis, especially. Okay, which will support for the principal diagnosis. So which need to be considered. So based on the discharge summary, based on their policy, they will be coming up with the what principal diagnosis we need to take care of. Then one more thing is like false Claim Act. Okay, so we'll be discussing on the False Claim Act as well. Separately, we have a topic on this False Claim Act. In that, I will explain you what is False Claim Act. Here in the documentation also, we need to ensure that whatever the documentation is provided, that should be a documentation which is diagnosed or which is a procedure for form. That should be simply like a fraudulent data and you cannot provide. I cannot render the data for upcoding and downcoding and all. I cannot manipulate the documentation. That is very, very important. So those things are all controlled by the False Claim Act, or otherwise we call it as Lincoln Law also. The other term is the Lincoln Law. So we'll discuss in detail when we are discussing about the False Claim Act in the next chapter. Okay, then HIPAA compliance. Yes, HIPAA compliance is one of the mandatory one. Okay, so whatever the documentation they are going to provide, that should be under the HIPAA compliant, which is like they need to ensure the patient information, whatever the patient information is there, that is not leaking out. And the same way, you need to be very protective. So Health Insurance and Portability and Accountability Act, so which will ensures that patients' privacy and security in the documentation and diagnosis and the abnormalities or whatever the conditions we are coming across. Okay, so the coding ethical principle, code only what is documented. Yes, that is based on the False Claim Act. You can avoid that. And based on the based on the ACDS, that is a clinical documentation integrity specialty, we can able to come to the conclusion. Then query clarification documentation, which is like based on the HIMA, the query should be very clearly asked. Provider must independently determine the diagnosis, yes, and the basis on the CMS guidelines and based on the UHDSS that need to be done. Then queries must be auditable and defensible. Okay, again, this is also comes under the UHDDS and you can bring partially to the HIPAA complaints also. No DRG manipulation. Yes, drug related, diagnostic related group is one of the very, very important thing. So where it is based on the CMS official guidelines, you cannot manipulate that. That need to be very clearly followed. Okay, so these are the some of the points. Okay, some of the elements we can tell are some of the categories, some of the scenarios, and some of the requirements for the provider codes. So all these 6 topics, yes, as I told, we need to be very clear. Like when you read the documentation, when you read the scenarios, especially in the exam, you need to understand what they're trying to ask, in what basis they're trying to ask. Okay, so based on that, whether these questions need to be taken through or whether this is a really provider query or this is a what type of provider query. So they may give you the example and they may ask what type, or they may give you a type and they may ask to give you the example. And they will ask you a question like whether it is a provider query or not, yes or no, or they may ask true or false. So anything may come. Okay, so analyze properly, come to the conclusion, come to the understanding, then you have to bring it to a proper understanding, then you need to give an answer. That is very, very important. So we have the questions for this as well. Okay, for the practicing, please go ahead and practice. Okay.